Good day, and welcome again to Learning Pharmacology with me, Nurse Myron. And today, we will be discussing the different drugs that affect the respiratory system. For our full disclosure, I'm not affiliated with any of the manufacturers of the drugs or other items mentioned in this lecture. The mention of such brand names are only in passing and for educational purposes only, and are not for commercial promotion. I have no actual or potential conflict of interest in relation to this presentation. So let us begin with a brief review of the anatomy and physiology of the respiratory system. The respiratory system is responsible for gas exchange. It oxygenates blood and removes carbon dioxide to be exhaled by the body. It also maintains the acid-base balance through ventilation and perfusion coordination. The human has two lungs, the left and the right. The left lung has two lobes, while the right lung has three. The respiratory system consists of the upper airway and the lower portions. The upper airway includes your nose, pharynx, and larynx, while the lower airway includes the trachea, bronchi, bronchioles, and the alveoli inside the lungs. The diaphragm is an accessory muscle that helps to control breathing. Gas exchange occurs in the alveoli, where oxygen diffuses into the capillaries and carbon dioxide diffuses out to be exhaled. Breathing is controlled by the respiratory centers in the brainstem, with muscle activity coordinated between the diaphragm and the intercostal muscles. Mucosal linings secrete mucus to trap particles, and your hair-like cilia move mucus upward to clear the airways. This is a cross-section of the bronchus showing the different parts where you can see the actual opening for the airway inside, and you have the different glands that produce mucus to trap any foreign bodies. The anatomy of the bronchus is very important, especially when we discuss the different drugs that will affect the airway later on. So now we focus on the pathophysiology of certain conditions involving the respiratory system. Disorders of the respiratory system include allergies, infections, inflammation, chronic obstructive pulmonary disease or COPD, and asthma. Often, these drugs require pharmacologic interventions. The mechanism that triggers bronchoconstriction involves an antigen triggering a receptor, which eventually triggers the cascade involving histamine, arachidonic acid, and prostaglandins. These eventually trigger the inflammatory response that triggers smooth muscle contraction, resulting in bronchoconstriction. For example, in asthma patients, certain allergens can trigger this response. Eventually, this cascade will stimulate certain chemicals that will eventually trigger the T cell adaptive immune response and B cells, eventually resulting in bronchoconstriction, increased mucus production, and bronchospasm. So here in this photo, you can see on the left your normal airway, where air can easily pass through without any problem. On the right side, however, you can see a highly constricted airway, and you can see the inflammation in the smooth muscles of the airways. Meanwhile, in this photo on the left, you can see your normal bronchus. Again, the airway is open, which will allow the easy passage of air in and out of the lungs. In the middle portion, you can see the inflamed bronchus with some mucus secretions. And lastly, on the right, you can see a highly constricted bronchus with your swollen mucosa. The latter two photos or pictures are typical in diseases like asthma and COPD and must be addressed using pharmacologic therapy such as these drugs that we will be discussing in this lecture. Recall this graphic from our recording on the topic of anti-inflammatory agents as part of the series Learning Pharmacology with me, Nurse Myron. So here, certain triggers will initiate this process, turning phospholipids into arachidonic acid. Then, the LOX enzyme will convert arachidonic acid into leukotrienes, which are responsible for respiratory symptoms of bronchoconstriction, increased mucus production, and increased vascular permeability. So now we proceed to the different drugs that are used for obstructive airway diseases, and we begin with your short-term therapy. In most cases of asthma and COPD, beta-2 inhaled agonists are the drug of choice given. These agonists initiate a cascade that causes an increase in your cyclic adenosine monophosphate or CAMP levels. In airway smooth muscle, relaxation is induced, which relieves bronchoconstriction. They are often started as treatment for asthma and COPD, often delivered via metered-dose inhalers. They try to maximize local lung impact while minimizing side effects like tachycardia. These are known as your short-acting beta agonists or SABA. From the name itself, SABAs are short-acting, with their effects usually lasting only for about 4 to 6 hours. However, their onset of action is quite fast. They are known as relievers and often provide relief within minutes. Common examples of your SABAs include your salbutamol, known as albuterol in the United States, under the brand names Ventolin, ProAir, or even Proventil. Another example of SABA is your levalbuterol under the brand name Zopenex. Next, we have your muscarinic antagonists. These are considered as anticholinergic drugs. If you will recall, acetylcholine initiates your parasympathetic nervous system response, responsible for the contraction of smooth muscles, leading to bronchoconstriction. Anticholinergics act against this. They block muscarinic receptors, thereby preventing bronchoconstriction and promote bronchodilation. In asthma, muscarinic antagonists act as bronchodilators by blocking muscarinic receptors, thereby preventing airway smooth muscle contraction and mucus secretion. Now we move to your drugs used for obstructive airway diseases, long-term therapy. Steroids or corticosteroids are used as long-term therapy to suppress airway inflammation. Often, these are given as monotherapy or in combination with long-acting beta agonists or long-acting muscarinic antagonists. Steroids work at the genetic level by suppressing inflammatory genes. You may be already familiar with steroids in our previous discussion on anti-inflammatory drugs. Here you can see examples of steroids used specifically as inhalation. For example, beclomethasone, budesonide under the brand name Budecort, ciclesonide, mometasone available in spray under the brand name Nasonex, Momate or Mosa spray, and fluticasone and triamcinolone. Other steroids given orally or intravenously include dexamethasone under the brand name Desilone, methylprednisolone, prednisone, prednisolone, and hydrocortisone. IV forms are usually given for severe asthma reactions or even in severe COPD, and they act very rapidly. Recalling the inflammatory response, mast cells produce leukotrienes, which triggers bronchoconstriction. Therefore, leukotriene modifiers are the drugs of choice to block these leukotriene receptors, thereby preventing smooth muscle contraction and promoting bronchodilation. Common examples of leukotriene modifiers include your Montelukast under the brand name Caster and Montijet. Zicast, the brand name, is a combination of Montelukast with levocetirizine. Another drug under this category is your Zafirlukast under the brand name Acolate. Other drugs include your Zileuton or Zyflon, which prevents arachidonic acid conversion into leukotrienes. By reviewing this graphical representation, we can recall the inflammatory process and see that leukotrienes are part of this. The drugs that we mentioned earlier act by blocking the leukotriene receptors, thereby putting a halt to the process. Next, we have your mast cell stabilizers. These drugs inhibit the release of inflammatory mediators from mast cells, thereby preventing early phase response from even starting. These are typically used prophylactically, but not for acute treatment in asthma. Cromolyn falls under this category. However, presently, these are not readily available in the Philippines. Next, we have your long-acting beta agonists, or your LABAs. These are bronchodilator medications that relax airway muscles to improve breathing in asthma and COPD patients. From the name alone, it is easy to identify that these drugs have a long-term effect, usually for about 12 hours. They are usually taken daily for long-term maintenance and not for quick relief. For asthma, LABAs are typically used in combination with other inhaled corticosteroids that we have discussed earlier. Common examples of your LABAs include salmeterol. When combined with fluticasone, this is marketed under the brand name Seretide, such as the Seretide meter-dose inhaler or Seretide Discus. Arformoterol under the brand name Brovana, formoterol under the brand name Foradil. But formoterol is more commonly combined with budesonide and sold under the brand name Symbicort, as we can see here your Symbicort Turbohaler. One ultra-long-acting LABA is your Indacaterol or Onbrez. Nursing responsibility in LABAs and most other inhalers include proper administration of these drugs. For example, Indacaterol or Onbrez is available in capsule form. However, this is not given orally. Instead, the capsule is placed inside the Onbrez breathhaler, where a small needle will prick the coating of the capsule, thereby releasing the powder inside, which the patient will inhale after breathing deeply. Symbicort Turbohaler and Seretide Discus have similar uses. On the other hand, we have your long-acting muscarinic antagonists, or LAMAs. These are inhaled bronchodilators that are given to relax airway muscles and are used to treat COPD and asthma by blocking acetylcholine. LAMAs are given once a day and provide 12 to 24 hours of action. They are currently the staple drug of choice for reducing COPD exacerbations and are sometimes used as add-on therapy with inhaled corticosteroids for severe asthma. Common examples of your LAMAs include tiotropium under the brand name Spiriva, aclidinium under the brand name Tudorza, and umeclidinium under the brand name Ellipta. Similar to Onbrez, Spiriva is also available in capsule form. However, these capsules are also not given orally. Instead, they are placed in HandiHaler device specific for this drug and inhaled in powder form. Correct use of these inhalers include deep breathing exercises before, then deeply inhaling to promote the intake of the powder from the mouth to the lungs. These drugs can have side effects of dry mouth, therefore, gargling after use is indicated. Other side effects may include constipation and potential urinary retention. Next, we have your phosphodiesterase inhibitors. This class of medications block PDE or phosphodiesterase enzymes by preventing the breakdown of cyclic AMP. These secondary messengers regulate cell functions that lead to improved blood flow, such as vasodilation and bronchodilation, and reduce inflammation. They are primarily used in pulmonary hypertension and COPD. A common drug under this category used for respiratory diseases include your aminophylline, under the brand name Euphyline, given intravenously, and Minimal, given as tablet. Other phosphodiesterase inhibitors include your theophylline, under the brand name Nuviline, doxophylline under the brand name Ancimar, and roflumilast. Next, we have your antihistamines. Antihistamines are primarily anti-allergy medications that are given to block histamine receptors. Some antihistamines, like clemastine, may have weak secondary bronchodilating effects. However, antihistamines are not a replacement against standard inhalers or other drugs in treating asthma and COPD. Antihistamines primarily reduce histamine-mediated response. If you will recall, in allergy and inflammation, there are four main histamine receptors: your H1, H2, H3, and H4. H1 are typically found in vascular endothelial cells, smooth muscle cells, the brain, and peripheral nerve endings. They mediate inflammatory and allergic reactions. Meanwhile, H2 receptors are also found in the brain, smooth muscles, the heart, and the stomach. While H3 receptors are also found in the heart, the GI tract, in the nervous system, and in the case of our discussion today, in the lungs. H4 receptors, meanwhile, are also found in the GI tract and in other organs. In the typical allergic response, an allergen will trigger B cells and become plasma cells to produce immunoglobulins, which bind to mast cells, eventually releasing granules and triggering the production of histamine. Antihistamines include your first-generation H1 blockers. These are inverse agonists that bind to H1 receptors. They inhibit histamine action, thereby stopping inflammation, itchiness, runny nose, and sneezing. Because they are older generation antihistamines, they easily cross the blood-brain barrier, which can cause significant sedation, drowsiness, and some anticholinergic side effects such as dry mouth and blurred vision. First-generation H1 blockers are used for allergies, motion sickness, and nausea. First-generation H1 blocker antihistamines include the very common and popular diphenhydramine under the brand name Benadryl AH. Other examples include your chlorpheniramine, also known as chlorphenamine here in the Philippines. Clemastine is more popular here as meclastine, doxylamine under the brand name Unisom, hydroxyzine under the brand name Iterax, cyproheptadine under the brand name Periactin, and another popular drug, your meclizine, under the brand name Bonamine. Another drug, your promethazine or Phenergan, is also popular. After your first generation, we have your second generation H1 blockers. Their mechanism of action is essentially the same as your H1 blockers first generation, but significantly, they do not cross the blood-brain barrier. Therefore, they produce less sedation. Likewise, second-generation H1 blocker antihistamines are selective for H1 receptors against allergies. These drugs include your cetirizine under the brand name Virlix and Benadryl 1. Take note, Benadryl AH is diphenhydramine while Benadryl 1 is cetirizine. Other second-generation H1 blocker antihistamines are levocetirizine, loratadine, desloratadine, fexofenadine, azelastine, and your olapatadine, which is available as a nasal spray. Now we move on to a different category of medications that are used for cough. These include your antitussive, expectorants, and your mucolytics. But first, we need to review cough or tussis. Cough is a reflex mechanism of the human body to clear airway secretions and foreign particles. Cough receptors are present in the trachea and the pharynx, and when stimulated, they send signals to the cough center in the brain via the trachea and the vagus nerve. In return, the brain initiates a cough reflex via the vagus nerve to contract the diaphragm and intercostal muscles. This creates the negative pressure. The purpose of this is to remove any irritant in the lining of the respiratory system. Antitussives have side effects such as your headache, sedation, dizziness, and drowsiness, especially for your opioid antitussives. Opioid antitussives also have the risk for addiction and abuse. These antitussives are contraindicated for asthma and COPD and for pregnant women. Next, we have your expectorants. These drugs act by reducing the viscosity and liquefying the lower respiratory tract secretions or the mucus. Expectorants are used for the symptomatic relief of respiratory conditions characterized by a dry and non-productive cough. Common examples of your expectorants include guaifenesin under the brand name Mucinex, Robitussin, Guaimed, and Guaiflem. Next category is your mucolytics. From the name itself, mucus and lysis, these drugs act by breaking down the mucus. Therefore, they help high-risk respiratory patients in coughing up thick and tenacious secretions. Mucolytics are used exclusively for productive cough in chronic obstructive pulmonary disease, cystic fibrosis, pneumonia, or even tuberculosis. Common mucolytics include your acetylcysteine under the brand name Flumosil and Mucomyst, and Dornase alpha under the brand name Pulmozyme. Acetylcysteine is available in tablet form. However, this is not given per orem to be swallowed whole. Instead, Flumosil or Mucomyst tablets are placed in a glass of 1/2 glass of water and allowed to dissolve over a few minutes. The resulting solution, a bubbly, sweet-smelling, similar to a carbonated drink, is then taken by the patient, usually once or twice a day, depending on the order of the doctor. Lastly, nurses should teach our patients regarding adverse effect monitoring. For example, certain anti-asthma medications and bronchodilators can have a side effect of tachycardia and tremors. Instruct the patient to report any palpitations. Corticosteroids can result in hyperglycemia, immunosuppression, or dry mouth. Expectorants and mucolytics can produce increased sputum and therefore more cough. That is why it is essential to counsel our patients regarding the possible effects of these drugs. I hope that you learned a lot in our discussion on the drugs that affect the respiratory system. Thank you for listening, and I hope you enjoyed learning.